Thank you so much for that introduction and for inviting us to present today. Our presentation is titled The Pediatric Intensive Care Unit, Dysphagia Management in the Trenches. We're looking forward to sharing with you relevant current research, as well as our experience in the ICU, which guide our assessment and management of swallowing impairments in the early stages of critical care. But we do hope this information will be applicable for those caring for patients after ICU discharge by lending a better understanding of their hospital course and special considerations. Before we begin, we do need to mention that we each receive an honorarium from Dr. Brown's Medical for this presentation and have no other financial disclosures to share. We are both speech pathologists practicing at a large tertiary pediatric teaching hospital in Texas, but all opinions we express today are our own. With that said, we'll get started. So by the end of today's presentation, you'll be able to describe 3 factors that a clinician should consider when determining timing of evaluation of swallowing in the pediatric intensive care unit, list 2 special considerations when evaluating the feeding or swallowing of a tracheostomy-dependent infant, and describe 1 way to facilitate the continuum of care for infants who do continue to exhibit feeding or swallowing difficulties post-discharge from the intensive care unit. We'll begin by painting a picture for you of the pediatric intensive care unit, or ICU, and sharing considerations for how the setting itself, as well as the medical complexity of the patients, impacts the timing and nature of our swallowing evaluation in these cases. We'll have 2 specific case studies to present to you today. We'll also touch on the continuum of care at the end of our discussion. So here we have definitions. Let's define the ICU. It's a specific unit within the hospital which is best equipped to provide medical care for our most critically ill patients. It is distinct from other acute care units in its enhanced capacity for monitoring, as well as ability to provide multiple modalities of physiologic organ support to sustain life or life support during a period of life-threatening organ system insufficiency. ICUs may be subdivided by specialty. So a patient may be admitted to the neonatal ICU or NICU, cardiac ICU, neurology ICU, or surgical ICU if requiring specialized intensive care. However, the PICU or pediatric ICU provides care generally for pediatric patients ranging from neonates up to teens. Today, we are primarily focusing on infants in the ICU. Both of our case studies today were actually admitted to the pediatric ICU rather than the neonatal ICU because this was not their initial hospital encounter after birth. Often, patients admitted to the ICU will carry the primary diagnosis of serious injury to or failure of 1 or more major organ systems. The list we'll give you here is not all-inclusive, but does give you a sense of what we frequently find on chart review when consulted to evaluate a patient in the ICU. Cardiac failure, which in the pediatric population often arises from congenital heart defects. Respiratory failure, which includes everything from asthma and acute respiratory distress to apnea and need of mechanical ventilation. Neurological concerns such as seizures, head trauma from accident, abuse, or injury. Kidney failure, liver failure, as well as other more general critically ill patients recovering from trauma or surgery, sepsis, poisoning, intensive chemotherapy, or possibly awaiting organ transplant. Our patients may come in through the emergency room and then admit directly to an ICU, or they can be transferred from a lower level of care due to an acute decline in their medical status. When thinking about the setting, when we walk into an ICU bed space, there will be numerous pieces of equipment providing support and monitoring the patient. The child will typically be connected to multiple monitors tracking their vitals, including heart rate, respiratory rate, oxygen saturation, and blood pressure. NIRS or near-infrared spectroscopy may be in use to measure regional oxygen saturation, which is an indication of perfusion and oxygenation status of tissues and provides information on brain and organ function. You can see the NIRS here attached to the forehead and later the abdomen for that purpose. They'll have various lines, drains, and tubes. For patients in respiratory failure, they may be intubated or dependent on a trach and vent. For patients in heart failure, we may see a ventricular assist device, or VAD, which is a heart pump that maintains blood flow and serves as a bridge to heart transplant. As you can see in this picture, the scene becomes very complex with a patient attached to this amount of equipment. So it's important to know what we're looking at before working with the patient, especially if we're planning to adjust their positioning for our evaluation. This particular patient you see here is orally intubated and very likely sedated and not yet appropriate for a full evaluation. But were she awake and possibly trached or maybe on a lower level of respiratory support, we could hypothetically begin our assessment while the rest of this equipment seen here remains in place. Beyond the equipment, we also need to consider the patient's medical status, which may be up and down while in the ICU. The patient may still be fairly unstable this early in their hospital course. They may return to the operating room for additional procedures. They're also frequently weaning sedation and pain medications, which is a stepwise process. We need to think about how many meds they're on and what are they weaning, how far down the step ladder they are. We know that patients will be drowsy when on these medications and can be irritable or agitated when withdrawing the medication. So it's helpful to know when and how often they're receiving their doses when we're timing our assessment. Look for a time when they'll be most alert, less likely to be experiencing symptoms of withdrawal. Another aspect of medical status to consider is the level of respiratory support that the patient currently requires, which we've arranged here in a continuum from greatest degree of support to least. On the far end, we have intubation, followed by CPAP, or continuous positive airway pressure, high flow nasal cannula, standard or low flow nasal cannula, and finally room air, meaning no support required. It's important to keep in mind that each patient's course is not necessarily going to be linear. For example, they may initially extubate to nasal cannula, but if they do not tolerate this, the medical team may need to escalate their support back up to high flow or CPAP, then gradually work them down toward room air again. There are various reasons why the medical team might determine to go the route of placing a tracheostomy rather than maintaining intubation and ventilation that way. So tracheostomy could provide a longer-term respiratory support, and it has a continuum of its own, but we'll touch more on this during our first case study. Another special consideration for the intensive care unit is the possible presence of delirium, which is a syndrome of acute central nervous system dysfunction with acute change in behavior and cognition. So some cardinal features of delirium for our older patients can include changes in their level of awareness, their ability to sustain attention. You may see associated cognitive and behavioral features like thought and behavioral disorganization, disorientation, memory deficits, or psychomotor agitation. But when we think about delirium in our younger patients or our infants, they're more likely to present with sleep-wake dysregulation, with the patient appearing inconsolable and restless. So delirium is generally multifactorial. It's caused by an underlying physiologic disturbance, which can often just be their medical condition that they're admitted for, but also prolonged or excessive use of sedatives, among other factors. Infants are surprisingly at a higher risk for delirium than older patients due to the relative immaturity of their central nervous system. So some other factors for delirium may include delays in cognition, motor function, or language, which can result in a 3.5 times greater risk. Patients who are mechanically ventilated are also at a higher risk. So we know that delirium can be precipitated by certain events, but it can also be perpetuated by environmental factors like loud noises and lack of mobility, things that are pretty common in the ICU setting. So these are important to us because it's just another factor to keep in mind about the patient's overall status while they're in the ICU. If our infants in this setting are restless, they're inconsolable, they have poor sleep-wake regulation, we are going to have increased challenges in evaluating and treating their feeding and swallowing. So the treatment of delirium is also multifaceted, and it can include medication management, but a big part of a big part of treatment is environmental modification, which we as nurses and therapists, we can help play a role in that in the ICU. So I know we realize that we have unique challenges when we work with families of children who have feeding and swallowing difficulties in any setting, but the ICU specifically presents to be challenging just because of how high stress this experience can be for families. There's quite a bit of literature discussing this stress on families, and it's even well documented that many of these parents can experience post-traumatic stress disorder after having their child stay in the pediatric ICU. While we have little control over how stressful this experience is for families, we can do our best to provide trauma-informed care, which that really just means that we're being sensitive to the reality of how traumatic this experience is for these families, and we're trying to adjust the way that we interact with them accordingly. So some of the things that we like to do in the intensive care unit to help our families, we like to make sure that we introduce ourselves multiple times and clearly state what we're there to do for their child. So even if I came by yesterday and started my evaluation, when I come back today, I'm still going to tell them my name, the service that I'm from, what I'm there to do, because they've probably met multiple people since I came yesterday, and it can be challenging for them to keep everything straight. We also find that the parents can have a limited capacity to take in just large amounts of information at this point. So we do try to keep as concise as possible in our communication with them, especially in the beginning. We also find it helpful to provide visual aids for education and try to limit large amounts of verbal education that they're not really able to refer back to later on. So now that we've touched some on considerations about the patient's overall medical status in the ICU, I'd like to discuss some specific considerations when we're thinking about actually evaluating these patients. So one thing to consider in the ICU is that even patients who don't necessarily have a diagnosis that might predispose them to dysphagia could have post-extubation dysphagia. There are 6 mechanisms well documented in the adult literature that cause post-extubation dysphagia, and I've listed them here at the top. So this is well researched in adults, but there's somewhat limited research on this in pediatrics. But there was one study completed by Hofmeister that was published just last year, and in their study, they hypothesized that children would have equal or higher prevalence of post-extubation dysphagia than adults, and their findings actually supported this hypothesis. They found that 29% of pediatric patients in their study experienced post-extubation dysphagia. What I also found fascinating is that they found that the odds increased for every hour of intubation, and we'll sometimes have patients in our ICU that can be intubated for weeks, so it's interesting to think about how much their odds can be increased. They had also found that patients less than 25 months of age had a much higher chance of having post-extubation dysphagia than patients older than that. So I do certainly applaud the authors for this study. It's a great place to start. We definitely need more research like this in pediatrics. But I will mention that one limitation of this study that I found is that they determined the presence of dysphagia only based upon clinical or bedside reports of signs of aspiration versus completing a more objective instrumental evaluation of swallowing. That being said, it really probably makes the actual number even higher due to the high incidence of silent aspiration in pediatric patients with dysphagia. So it's quite possible that they were getting some false negatives, or patients that, did not show any signs of aspiration based on a bedside evaluation, but had they possibly completed an instrumental evaluation, those patients might have presented with aspiration. So often in the intensive care unit, we'll receive our order to evaluate the patient before they're truly ready, but how are we defining ready? So we look at a combination of factors. To begin with, their overall alertness. Kim had touched on this a little bit earlier, but we do chart review and look at what types of sedatives or narcotics are they on. If they're on a lot of medications that could reduce their alertness, what's the weaning plan for that? Sometimes it's spelled out really nicely in the chart so you can see what the weaning plan is and know when your patient is less likely to be affected by that. On the flip side, it's equally important to know if the medications are being weaned really quickly, is the patient potentially experiencing any withdrawal symptoms? This can make our young patients really inconsolable and difficult to assess. So typically you can find WAT scores or the withdrawal assessment tool charted, and that's just a system where point values are given by nursing staff for certain behaviors or symptoms of withdrawal, and the higher number, the more of these your patient is experiencing. We'll also look at their level of respiratory support. So we know we're not going to evaluate their swallow if they're still intubated or if they're on CPAP, But what about high flow nasal cannula? This is a little bit of a hot button issue right now in our field, and there's not great research in pediatrics right now. So we tend to just try to look at the overall medical picture. We know that if they're going to significantly wean the flow later in the day, we might opt to wait for our evaluation until the afternoon when they're potentially closer to their respiratory baseline, especially for a patient that has a high risk of dysphagia based on their medical diagnosis, or especially if they have a history of dysphagia, we're likely to be a little bit more cautious with those patients. So do we look at the timing after extubation? There's limited information on this in pediatrics, but per the more recent adult literature, we're finding that it's not as necessary to wait a certain amount of time after extubation to initiate our evaluation. There used to be kind of like a blanket rule in many ICUs that we would wait 24 hours to evaluate, but it's turning out that that's maybe not quite as important as we thought that it used to be. So I will say we keep in mind that just because we go to the bedside to evaluate doesn't necessarily mean that that evaluation is going to be all-encompassing or complete. We might go to initiate the evaluation and then we realize we can't assess as much as we really wanted to or needed to because of limitations in the patient's alertness or tolerance to the assessment. It's not uncommon in the ICU to need to do multiple clinical evaluations over a period of time or over multiple days versus that pattern of doing an evaluation and moving right into a treatment plan. I do want to touch briefly on some things that you can do if you're looking at some of these factors that we just discussed on the last slide and you determine your patient isn't quite ready for a full feeding and swallowing evaluation. We'll often go to the bedside daily and we'll look at alertness, state, cognition. You can get the patient out of the bed and just assess their tolerance to being touched, handled, and held, how alert they remain for that. If this patient is really deconditioned and has been laying in the bed intubated for a while, you may find that they fatigue even just being removed from the bed and interacted with. In our patients with neurologic deficits, we might even begin to look at their ability to track and interact with us, as well as early developmental aspects like smiling and cooing. We know in our neonates how important it is to provide oral stimulation and pre-feeding experiences. Obviously, many of our infants in the PICU are older and they've eaten successfully by mouth in the past versus our preterm infants that we're preparing for their first oral feeds. But we do still find it important in these kiddos to maintain their oral skills that they have established while they're NPO and provide positive touch to them. So we'll often teach our families or even bedside nurses positive touch to the face, to the mouth. We'll teach appropriate facilitation of non-nutritive sucking on the pacifier. You can encourage facilitation to bring the infant's hands to their mouth for oral stimulation and exploration. And we'll also encourage providing this oral stimulation and providing the pacifier for sucking during their gavage feeds or their tube feeds. So this way, if this patient's been experiencing a prolonged period of tube feeding, we can kind of start to rewire them towards feeling full and associating that feeling with sucking to kind of prime them for oral feeding. We might even offer pacifier dips or coating the pacifier or maybe the infant's fingers in milk and allowing them to have some taste of that during their tube feedings when they're more alert, but they're maybe not quite ready to progress to a bottle or a breast trial where the patient would have to manage sequential boluses. This can also be a really good exercise for our infants who are maybe more awake and alert, but they're still weaning their respiratory support. Something else we can work on is environmental modifications for the patient's room. So I talked a little bit earlier about how environmental modifications can be a big part of treatment for delirium. And so this is where some of that comes in. Now, luckily in our hospital, we have really great child life therapists who will do a lot of this for us, but obviously not all hospitals have access to that. So you can recommend and provide developmentally appropriate modifications yourself. For example, we might discuss with staff on trying to cycle the lighting in the room between dark and light to help improve their sleep-wake cycle. And then if it's possible, based on your unit, we like to try to recommend if they'll just open the blinds and use natural light versus fluorescent light for the patient. So these are all things that we consider pre-feeding interventions, and they give you a way to intervene early on, which tends to make our job easier than when we go to do the actual full evaluation because we're already addressing these things early. We have a better indication of the patient's level of functioning. So this is really just a way to show you that, even if the patient's not ready for the first feed, there's plenty of things that we can be doing therapeutically that can make a difference. So once we start to think about doing our actual clinical evaluation of swallowing, there's some foundational information that we really need to know first. The history is an important part. If we can know the feeding and swallowing history, that's helpful. But in this setting, sometimes we have to ask ourselves, is there even a family there to provide a reliable history? So for example, we may have a patient that has a non-accidental trauma and the parents aren't allowed at the bedside. We could have potentially no idea what their baseline feeding and swallowing history is. And what's a little bit more unique in infants and young children in the PICU versus our adults in the ICU is that these patients have a new onset feeding and swallowing disorder, but they were also still learning to eat in the first place. So they can have quite variable feeding skills from one patient to the next. We also like to know if they have a history of dysphagia. So we see pretty medically complex patients, and it's possible that they have a history of a feeding or swallowing difficulty. Now, if they have a history of dysphagia, in the most ideal of circumstances, we can initiate the evaluation based on a previous instrumental report, a video fluoroscopic swallow study, or a FEES. However, this could have been completed in an outside hospital, and what we have is limited or absent, or maybe they've never had an instrumental, but the parents tell us they just have a history of difficulty, but they may not be able to describe that accurately, or we may not know exactly what's going on. So that just adds an extra layer of complexity to some of these children that we may be a little bit more cautious going into our evaluation if we know that they have baseline issues that could be compounded onto something new. So if we have zero history, no family at the bedside, and they're a young infant in this 0 to 4 month range, where we know they're only probably either breastfeeding or bottle feeding. If there's no family there, we know we're starting with the bottle. So we'll generally bring our hospital disposable nipples and then also our Dr. Brown's bottle system with several flow rates to the bedside. And then we'll just do our best to choose the flow rate to initiate the evaluation with based upon the patient's age, maybe just how they look overall, how concerned we are that they may have swallowing difficulties. Now, the older infants get to be a little bit trickier where you get in that 6+ month age range because there's wider variability in what they may be doing. Some 6-month-old infants might just be bottle drinking, whereas you may have another 6-month-old infant that's on a bottle, they've started a cup, they started spoon feeding. So we'll tend to bring a lot more equipment to the bedside, and we just have to explore their skill set a little bit to figure out where they're at in their development. If we do have a family there and they tell us that, oh, the baby bottle feeds, but they also cup drink, but then they tell us that maybe they just started cup drinking a week before admission, this may be a situation where we opt to go with their more established skills first and then bridge towards the skills that they were still developing. So I will mention that most of our patients proceed to instrumental evaluations just based on some of the limitations that we know are present from a clinical evaluation. So there was one recent study out of Boston Children's Hospital that found that the sensitivity for predicting aspiration based on a clinical evaluation was only 44%. And they were unable to identify any single symptom that could reliably predict which patients would have evidence of aspiration on a video fluoroscopic swallow study. Also, they noted that 1/3 of their patients that had a, quote, normal clinical ended up actually having aspiration on a video fluoroscopic swallow study. So for these reasons, in combination with other similar research, many of our patients do end up receiving an instrumental evaluation, but we do use our clinical to really prepare us for the video fluoroscopic swallow study or FEES. This really is our time to determine what their oral motor skills are, what interventions make any kind of difference. This helps us determine a hypothesis for what the pharyngeal phase of their swallow might look like and what all we want to investigate further during an instrumental evaluation, where we tend to have less time to do these things than we do during the clinical. The clinical evaluations also help us determine the best timing for our instrumental evaluation. So we try to do our instrumental evaluations in the best timing possible for the patient so that we can set them up for success, and we're ensuring that our results are reliable. So for example, the patient might be ready for a clinical evaluation, but we may decide that we want to wait until they're a little bit further along in their medication wean to make sure that they're consistently alert enough for the exam. So obviously for a bedside or a clinical, we can come by when the patient's most alert. We might contact the nurse and have her call us when the patient wakes up, but our instrumental evaluations have to be scheduled in advance. And then if the patient's not consistent, it's possible we could end up completing the instrumental at a poor time for the patient. So once we do decide that we need to do an instrumental for the patient, we also have to carefully choose which exam we think is best for our patient. In our ICU and in many ICUs, we have both the FEES or fiber optic endoscopic evaluation of swallowing and the VFSS or the video fluoroscopic swallow study available to us. While I do feel like the FEES is really great for the ICU population because of its portability, I'll be honest in saying that the majority of our patients end up getting the VFSS first and then tend to get the fees more as a second exam. But I do want to point out a few differences between exams that we take into consideration when choosing. So the fees, there's no set time limit. So hypothetically speaking, if an infant could tolerate the scope passing and doing their entire bottle feed, we could watch that entire bottle feed from the beginning to end. Whereas on the VFSS, we're limited to just a couple minutes of radiation time. And so certainly we could look at more of the bottle feed, but we'll have to turn fluoroscopy on and off to limit that exposure. The fees I've already mentioned is portable and done at the bedside, so that's great for this patient population, because for the VFSS, we have to transfer our patients out of the room down to radiology, which they A, have to be stable enough for, and then B, all of their equipment, lines, things like that have to go with them. I will say the reason that we tend to choose the video fluoroscopic swallow study as a first exam more often in our patients is just because it views the oral, pharyngeal, and esophageal phases, where on the fees, we're more limited to the pharyngeal phase. So we tend to get more information from our VFSS as a beginning exam and then use our fees for a repeat. Today's first case study follows the ICU course of a tracheostomy and ventilator-dependent infant. For anyone not working with trach and vent regularly, we'll go over a little bit of background before getting into the case study itself, beginning with what is a tracheostomy? As you see in the diagram, a tracheostomy is a hole surgically created into the trachea or windpipe through which a tracheostomy tube is placed, effectively bypassing the nose and mouth and creating a new airway. Why would a tracheostomy be placed? Firstly, the medical team may opt for a trach in the case of an airway disorder, which prevents the patient from getting a sufficient amount of air to their lungs on their own. Such disorders include subglottic stenosis or narrowing, webbing, paralyzed vocal cords, severe tracheomalacia, micrognathia, retrognathia, among others. A patient may also require a trach for airway clearance in the case of a neurologic or neuromuscular condition, which impedes their ability to protect or clear their airway on their own. Finally, we mentioned intubation earlier on our continuum of respiratory support. An endotracheal tube, which is used in intubation, is typically oral. It often requires sedation and does not allow the patient to eat by mouth. Also, for older patients, it makes verbal communication challenging. So if there's a prolonged need for mechanical ventilation, the trach is preferable. There are several types of trachs in use in the pediatric world. We'll always take into account what type of trach, what size, whether it is cuffed, and if it's cuffed, whether it's inflated or deflated prior to completing a swallow evaluation. The cuff in the diagram here is inflated, and as you can see, it completely separates the upper and lower airway without leak. We know from the adult literature that the presence of a trach alters the airway and the swallow significantly, with anywhere from 50 to 87% of tracheostomized adults experiencing feeding and swallowing problems in the research. And so far, research looking at similar problems in the pediatric population seems to agree. According to a study from last year, 70% of children with a tracheostomy tube presented with problems in their oral and/or pharyngeal phase of swallowing. And 43% of those children studied actually aspirated as well. When we think about why this would be, there's several possible reasons. And again, we pull from the adult research, looking at the changes a trach causes in the airway, and in turn to swallow physiology. Patients with a tracheostomy experience reduced laryngeal elevation during the swallow, which is an effect known as a tethered larynx. And they will also have reduced sensation in their upper airway and changes in air pressure. All of this can have an impact on their swallow. Even so, not all children with tracheostomies will aspirate, and many can go on to achieve safe oral feeding. Regarding infants specifically, a separate retrospective study we found that looked at oral feeding outcomes in infants with trachs showed that 43% discharged from the neonatal ICU on full oral feeds, and another 38% on combined oral and gavage, meaning that better than 80% of the study group were eating at least partially by mouth at the time of hospital discharge. They reported that infants in the first two groups who were eating by mouth were able to tolerate gradual decreases in their supplemental oxygen during their hospitalization, while those who failed to feed orally actually didn't and required increased ventilator settings over time. Which brings us to mechanical ventilation. A patient may require mechanical ventilation in addition to tracheostomy if their own spontaneous breathing is insufficient to bring enough oxygen to and release enough carbon dioxide from the lungs. Simply put, the ventilator will move air in and out of the lungs and lessen the work of breathing for the patient. You can see pictured here a hospital vent, which is connected to a patient in the crib on the left who's laying just out of frame here. Much like before, the degree of respiratory support offered by the trach and ventilator has a range that can be adjusted to the patient's needs. So on the more supportive end of the spectrum, we have hospital vents, like we just saw pictured, which are more standard for the intensive care unit. They're larger and they'll offer more settings. Once closer to discharge, if the patient continues to require mechanical ventilation, they'll be transitioned to a home vent. Either vent can offer higher or lower settings. And once weaned down to lower settings, we can initiate HTC or HME trials. HTC, or heated trach collar, is seen here, providing humidified air to this patient via their trach. The HME, or heat and moisture exchange, is also known as an artificial nose and is used to warm and humidify the air, which helps keep secretions thin. So when an infant has a new trach and is trach vent dependent, we have several considerations before going in to complete a feeding and swallowing evaluation. First, are they off fresh trach precautions? This usually lasts 1 week after the initial trach placement. Are they tolerating cuff deflation? If our patients are not tolerating cuff deflation, it tends to point to them being a bit not as medically stable, therefore not as ready to eat by mouth. Although the research is a little lacking, inconclusive, especially in pediatrics, we prefer cuff deflation prior to swallowing evaluation just because logically it allows for increased airflow to the upper airway and therefore improved sensation and greater chance that the patient could trigger a cough response in the event of aspiration. Can they tolerate a speaking valve? We'll look at this prior to swallowing evaluation because the speaking valve restores the patient's ability to exhale through their nose and mouth, again, improving sensation and helping to normalize subglottic air pressure, which can in turn improve outcomes in terms of airway protection. However, we know that children, especially those in the group under the age of 2 who have the smallest airways, may not always tolerate the valve. And if this is the case, it does not prevent us from proceeding with a swallow assessment. It's just something to try out beforehand. Finally, we'll think about the timing of evaluation related to any periods off the vent, such as HME trials, which may be scheduled during the day. The image you see here is a pediatric airway model, which we often use to explain to parents the changes to the airway after tracheostomy. Again, we find it's useful to provide visuals and avoid an overwhelming amount of verbal education for families in the ICU. This brings us to the case of Emily, who is a 3-week-old baby girl. She was born prematurely at 35 weeks and is diagnosed with spondylocostal dysplasia and scoliosis. Spondylocostal dysplasia is also known as Charcot-Levin syndrome and is comprised of multiple malformations of the vertebrae and ribs, which results in a short neck and trunk, scoliosis, and deformities of the rib cage. Emily required CPAP for 4 days after her birth, but was eventually weaned to room air and able to discharge home without respiratory support. She was fed fully by mouth via either a hospital slow flow or Dr. Brown's preemie nipple. When we met Emily, she had returned to the ER just 2 days after that discharge and was admitted to the PICU for hypoxemic respiratory failure. Emily just happened to be a December baby and was born right in the heart of cold, flu, and RSV season, which can be especially difficult for former preemies. She presented with increased work of breath and tachypnea with lots of panting and grunting, was placed on CPAP, and ultimately did not have to be intubated. She was weaned gradually down to 2 liters of oxygen via nasal cannula and was stable, but still sometimes tachypnic. The medical team determined that her respiratory failure was most likely due to a viral illness, but because she was still having some ongoing tachypnea, they ordered the swallow study to assess for any swallowing dysfunction that might be contributing to her respiratory distress. So we completed a bedside evaluation prior to taking her to fluoro. She was assessed with thin liquid via the hospital slow flow nipple and demonstrated reduced coordination of her suck, swallow, breathe sequence just due to that intermittent catch-up breathing and tachypnea. She also had reduced overall endurance for bottle feeding. And so we took her for a formal swallow study. Emily demonstrated functional bottle feeding skills, but somewhat reduced bolus control and containment. At the beginning of the exam, her swallow was initiated in the vallecula, but increasingly we observed delivery to and pooling in the piriform sinuses prior to swallow onset. That delay resulted in occasional penetration, which was at times deep, meaning the bolus made contact with the vocal folds without going below them. So we'll see that here in the first clip, but before it plays through, I just want to point out some general landmarks. In the upper left of the screen, you can see the contrast, which appears black, entering her mouth via the bottle. The dark pipe lining her spine is her esophagus, and the lighter pipe, more interior to that towards the left of the frame, is her trachea. You can also see her collarbones pretty prominently in these clips, which are somewhat higher up than we're used to seeing, and that's just due to her spondylocostal dysplasia. So this is a recording of thin liquid via a slow flow nipple from midway through the exam. You can see she's starting to fatigue and allow brief pooling in the piriform sinuses prior to the swallow. She's doing about 2 to 3 sucks per swallow, occasional penetration here and there, brief pooling, and then she triggers a swallow. So with thin liquid via the Dr. Brown's preemie, it's a similar story. She has some decent oral skills, but some delay in occasional penetration. We did not see any evidence of aspiration on this exam, so we recommended continuing with thin liquid via the Dr. Brown's preemie in sideline position with flow control as needed. As her story continues, Emily was unable to fully wean respiratory support due to inadequate ventilation, moderate retractions, and ongoing tachypnea. Her diagnosis was adjusted to restrictive lung disease with chronic respiratory failure, requiring non-invasive positive pressure ventilation. She was stable on BiPAP throughout the day and was able to come off for breaks onto 0.5 liter of oxygen via nasal cannula for oral feeding, but did have to return to BiPAP when feeding was completed. The medical team did also have some concerns for inadequate weight gain despite increasing her formula concentration. And at this point, she had no nasogastric tube or alternate means of supplemental nutrition. So the decision was made to place a trach and go ahead and proceed with a G-tube during the same surgery due to the high likelihood of feeding difficulty after her trach. With her trach in place, Emily tolerated cuff deflation and was given G-tube feeds while weaning sedation, and she also tolerated those tube feeds well. And 1 week after surgery, we reevaluated her oral feeding and found that she continued to demonstrate reduced coordination, but now with multiple stress cues and increased tachypnea. She had an overt cough during feeding, 1 bradycardia episode, and increased congestion. So knowing what we've discussed about the incident of dysphagia after tracheostomy, we were very concerned that her swallow safety was compromised. So for this reason, she was fed strictly in therapy, very conservative volumes, until she was able to participate in a repeat swallow study. So over the next 2 or 3 weeks, there were lots of adjustments to her vent settings, and she eventually completed her sedative wean and was transitioned to a home vent. So at this point, we recommended to go ahead and repeat the swallow study. Unfortunately, Emily's second exam was very limited. She demonstrated a variable suck-swallow pattern and quickly fatigued. Like before, this resulted in delayed swallow onset, but this time we did see some trace aspiration in addition to that penetration that was happening before. However, after the aspiration event, she refused to latch or accept any other nipples, so we were unable to determine if a change to flow rate or viscosity would improve her airway protection. Ultimately, we recommended that very conservative volumes be offered in therapy only, with her doctors and family acknowledging this risk. Our goal was just to balance her risk of aspiration with the need to provide safest possible practice of oral intake to maintain her skills and get her to a repeat exam. Emily had some variable participation with those therapeutic volume feeds. We were able to repeat her swallow study about a month later, but due to reduced interest and acceptance, we could only capture individual swallows. So you can see her trach tube in place during this evaluation. And as you see, she does not display sustained sucking bursts like she had on her initial exam. She just expresses a little bit of liquid out of the nipple, kind of triggers individual swallows here and there. Overall, very shallow, reduced latch, reduced expression, just disinterested in the feed. So while we found no evidence of penetration or aspiration on this swallow study, and because of her history of silent aspiration previously, coupled with how limited this sample was, we did recommend that she continue with G-tube as her primary means of nutrition, with therapy and mother offering small volumes once or twice per day to maintain her skills and improve her acceptance. She was pretty clearly at a risk of developing an oral aversion, so we emphasized to her family to avoid force feeding and to be sure to follow up with outpatient ENT and dysphagia therapy. And so she discharged on her home vent and continued to practice therapeutic bottle feeding. Fast forward to 6 months, and she returned for a speaking valve evaluation, which she tolerated well. She was taking minimal formula by bottle at that point, but seemed to enjoy starting purees by mouth. And she continued to work with therapy, and 6 months later, a 1-year-old is taking most of her formula now by mouth, eating solids and using single words. She continues to follow up with ENT and therapy services and is currently a candidate for decannulation or removal of the tracheostomy tube. Okay, for the next case study, we're going to discuss a little one who suffered from a brain injury. So brain injuries can come from a variety of mechanisms like a motor vehicle collision, a sports-related injury, or in this case, a non-accidental or abusive head trauma. We find, we find in the ICU that for our infants, the most common cause of brain injury tends to be these non-accidental abusive head traumas or drops and falls. These are some general deficits you may see in a patient with a brain injury. So cognitive impairment, impulsivity, agitation, sleep disturbance. While yet again, there's limited research in pediatrics, so research that has been completed when looking at the swallowing characteristics of pediatric patients with brain injury indicates that children with dysphagia after TBI have swallowing deficits similar to those noted in the adult TBI population. So these patients tend to have a combination of both oral and pharyngeal deficits and are at a higher risk for silent aspiration. So some of the specific swallowing characteristics that you might see in a patient after a brain injury: oral prep and oral phase deficits include a disorganized root and suck, or for our young infants where we know these things should still be reflexive if the brain injury is significant enough, sometimes we'll see that these reflexes are absent altogether with no rooting, no attempts at sucking. We can see reduced bolus control, impaired bolus formation. We might see tongue pumping, or when we're going to look at sucking, some of these infants can do more of like a munching, chomping compression pattern rather than true suction. We'll also see premature spillage into the pharynx as a result of their poor overall oral control of the bolus. Pharyngeal phase deficits can include a delayed swallow initiation. We might see residue, and then often as a result of the delayed swallow initiation, we can see penetration and aspiration. A study by lead author Morgan in 2003 describes some predictive factors for dysphagia in pediatric patients with brain injury. A score of less than 8.5 on the Glasgow Coma scale, or an indication of a severe brain injury, was the strongest predictive factor. But they also found that ventilation duration of greater than 1.5 days and compromised cognitive functioning were also predictive factors for dysphagia. And the GCS score and the ventilation duration findings, those are both consistent with findings in the adult literature. So let's talk about Daniel. Daniel was a previously healthy little 4-month-old boy who sustained a non-accidental trauma with a right parietal skull fracture, subdural hematoma, subarachnoid bleeds, and hypoxic ischemic encephalopathy. So he had a pretty significant injury. In the emergency room, he required 30 minutes of CPR and was intubated. He also ended up having seizures as a result of his head trauma. Daniel was transferred to the PICU for severe TBI management, where he stayed for several weeks. For a lot of his time in the ICU, he was intubated, sedated, and on continuous EEG, so it really did limit what we could do with him during his stay there. A lot of his stay we spent chart reviewing, awaiting readiness for our evaluation, and doing a lot of those pre-feeding interventions that we mentioned earlier in the presentation. So Daniel had a bit of a challenging ICU course. He was intubated for 13 days, and he had a difficult time successfully extubating to room air. So he initially was extubated to nasal cannula, but then he required increased support on high flow nasal cannula, which then increased to BiPAP. Then they were able to begin weaning him back down through CPAP, high flow nasal cannula, and eventually to room air. So it wasn't until several days after his initial extubation before he was finally stable without any support. So we had determined in collaboration with our doctors that because he had had such a tricky time extubating successfully to room air, that in that period of time, we were just doing the pre-feeding interventions and we weren't going to feed him even on like nasal cannula or high flow nasal cannula, just because we weren't sure if he was ever quite stable. So because we had been doing a lot of those pre-feeding interventions with him, once we went to do our clinical evaluation, we had a pretty good indication of where he was at as far as his alertness. But we did notice that he was awake, quite alert, good state regulation. His oral motor evaluation was characterized by him having good secretion management. He was able to produce a good non-nutritive or pacifier suck. But one thing that we did note was that the volume of his vocalizations or his cry was diminished, which did have us a little bit concerned that with how long he had been intubated, he could potentially have some laryngeal trauma. So Daniel was one of those patients where he was not allowed to have the family at the bedside, and so we did not have any feeding or swallowing history from him other than knowing that he was typically developing before. So we decided to start with a bottle with him because of his age, and we opted to go with the Dr. Brown's level 1 nipple because we thought that was an appropriate starting place just based on his age and how he was appearing at the time. His oral phase was characterized by an immediate latch, good suction, good tongue cupping, good expression of the liquids, but the pharyngeal phase was the bit more concerning part, where we did notice that he was getting some kind of congestion with audible gulping towards the end of the feed, and changing the flow rate of the nipple wasn't seeming to make a big difference for him. So we determined the need to proceed to an instrumental based off of his known risks, given not only his brain injury, but also the prolonged intubation and his weak cry. We had also asked the primary medical team if they would consult ENT to look at his airway because of our concerns about his cry after the prolonged intubation. So Daniel presented with both oral and pharyngeal phase deficits on his study, which I'll show you here in a second. His oral phase was notable for variable suck-swallow ratio, reduced tongue cupping, decreased rhythmicity, which all was a little bit interesting in that during his clinical, literally just the day prior, he had pretty good oral motor skills. So this can just go to show that sometimes our infants with brain injury can be inconsistent. I'll go ahead and play this first clip for you, and you can start to look at some of those oral phase deficits. Like I mentioned, his rhythmicity is not great. Pharyngeal phase, we'll also notice that he has a delayed swallow, which I think it's not until our second clip that you can see that that ends up resulting in some penetration and aspiration during the swallow. We assessed multiple nipples and consistencies on his exam, and he ended up doing best on nectar thick liquid. He had aspiration of thin and half nectar. So we made a plan with the medical team to continue to use his NG tube as primary and to offer therapeutic amounts of nectar thick liquids in hopes that we could continue therapy with him. We could work on his oral skills, work on practicing his swallowing, and hopefully repeat the exam during his admission. The medical team also did agree to consult ENT, and they found reduced vocal fold mobility, which is what we expected. So our time with Daniel in the ICU was pretty short because I mentioned that we met him at such a late part of his stay because of his complexity. Pretty quickly after his first swallow study, he ended up moving to the neurology acute floor, and we continued our treatment and management with him there. We ended up repeating a swallow study before discharge, and we found that he had improved oral skills, which you can see on this clip here. He did continue with a delayed swallow, but it was pretty, well, I want to say significantly improved, intermittently improved, we'll say. We were able to wean him from nectar down to half nectar, but he still wasn't quite ready for thin liquids based on this exam. At this point, Daniel was lucky enough to have a great foster family who was there at the bedside. So we were able to start training them to feed him thickened liquids, and he was able to end up discharging with no feeding tube and eating everything by mouth thickened. We ended up following up with Daniel in an outpatient clinic that we have so that he could see ENT and speech together. and to follow up on his vocal fold mobility and also his dysphagia. And during that visit, he ended up getting a FEES so that we could limit him from having another swallow study. And at this time, his timeliness was quite improved, and he was actually able to wean to thin liquids at this point. This was maybe a month or so after discharge. So I think it's important to note that while the 2 patients that we saw today had pretty good outcomes given their complex courses, the entire management of both of these patients did not occur exclusively in the ICU. So we'll typically meet a lot of our patients in the ICU, but then they continue to need therapy and dysphagia management across their entire continuum of care, which often moves from the ICU to the general acute floors and then into outpatient. So we always make sure at discharge that our patients have appropriate therapy referrals so that they can continue to have their feeding and swallowing deficits managed in the outpatient realm. And then in some times, like Daniel's case, they'll need specialty clinic follow-ups at our hospital or at other locations that we can help coordinate. So thank you all so much for listening today. We really hope that this presentation has been helpful for all of you, whether you work in this setting now or just receive these patients after they discharge from this setting. We hope that this has given you all some increased insight into just what these patients experience while they're with us and how to best treat them. And now I believe we have some time for questions.
So our first question is, why are patients who are mechanically ventilated at more risk for delirium?
So I would direct you to the article to look a little more in depth, but I think a lot of it just is related to the amount of sedatives and narcotics that those patients are on when they require intubation and mechanical ventilation.
Okay, and just so everyone knows, when we post, thank you, when we post the slides, we will, at the end is their reference list, and the reference list is attached to those slides at all. So you'll have access to all those articles. All right, the next one is, this is a good one. Do you have any suggestions on how to collaborate with all providers in the PICU to follow through on some of the environmental interventions that are recommended? Challenging for us all. So what are some tips from you about that?
So I would suggest if you can find a way to be present on rounds, that's always helpful. We've started on other units implementing kind of developmental care rounds to discuss some of those specific things. We don't have that in the general ICU just yet. But another way, I don't know if you guys have a way in your charts to communicate with your nursing staff, but a lot of the environmental modifications, if you don't have child life or other big therapy presence, is going to come from the nurses implementing that. And we have a place in our chart where we can put things that the nurses read before each shift change as far as what to implement at the bedside. So sometimes we'll put little tips and tricks there about things that help the patient during the day.
Great suggestion. Just from experience too, I have to say developmental care rounds are extremely helpful. So I think that's a great idea. Here's another one that I know a lot of people often wonder about. What do you use to thicken formula versus breast milk? Do you use gel mix? So what are you using in a PICU for thickening?
Well, that's usually a team decision, and it's going to vary. Frequently for our infants that are obviously under 12 months, we're going first to rice cereal. We're having to develop a plan for thickening at the bedside and then share that training and education with parents to make sure it's consistently getting to a significant thickness. And if we have an infant that's on breast milk and we can't use rice cereal, we do sometimes look to other products such as gel mix. And again, it's the same process of working through how to best thicken and train the family and work with the medical team to decide which is the best match for the family and the patient.
Okay, great. We have time for one more. How do you determine when an infant is ready for a milk-dipped pacifier prior to a feeding eval?
So some of the prerequisites that I'm looking for is obviously I want them to have a suck on just the dry pacifier first before we make that a little bit more challenging task for them. But as long as the infant is sucking on the pacifier, is relatively awake and alert and engaged, then most of our infants are appropriate for that because it's not really providing a bolus that they have to swallow. It's really just adding an extra sensory component of the taste for them.
Right. So as long as they can maintain a non-nutritive suck and keep a stable respiratory rate, they're not getting tachypnic or stressed just by the pacifier itself, then we can consider pacifier dips.
We also look at their secretion management. I know, I said that it doesn't add a bolus for them to swallow, but certainly if they're not even able to manage their own secretions, I don't like to add a ton extra to that. So that's another thing that we look for as well.
Great, thank you. We keep having questions coming in because so many of these are just very interesting topics. I'm going to just do one more because not everyone has worked with trach patients. So the last one, and then any other questions that come in, please, you can still email us and we will get them to Chelsea and Kim and they will be answered on our website. So the last one for sure this time is how to decide on initiate an assessment for a cuffed tracheostomy tubed patient.
So in our units, we generally aren't initiating an actual evaluation of feeding and swallowing if the cuff is inflated, but we do touch on a lot of the other things that we mentioned as far as we're looking at the developmental aspects of the patient, we're looking at non-nutritive. We might do like pacifier dips or small taste, but we're generally trying to advocate for cuff deflation for those patients if it's appropriate. Obviously, that requires us looking at the level of respiratory support that they're on, touching base with our pulmonologists, with our ENT, with our critical care teams. But a lot of the patients, if they really are appropriate in general for feeding and swallowing, they tend to be able to tolerate cuff deflation. But generally speaking, we're not initiating full swallowing evaluations for patients that still are requiring cuff inflation.
Okay, great. Thank you. Thank you again. I believe that's all we have time for. Again, if we didn't get your question, we will post them along with the answers when we post the recorded webinar. And as we wrap up this presentation, Dr. Brown's Medical would just like to thank Chelsea and Kim, as well as all of you who attended and took time out of your day. Our next webinar is in May, so please keep on the lookout for that announcement and have a great day, everyone. Thank you.